I think it was, now I see that it was sent to me specifically, so, yeah.
All right, so thank you, Dr. Larson, for sharing with us an update on COVID. And it's an ever-changing situation, so
Right.
I know I'm really grateful that we have a task force that helps us keep up with what's happening and how to move forward as a congregation. And I think Dr. Larson has some information that we would maybe just look at us as individuals, just evaluating risks and deciding what we choose to do for ourselves too. So thank you, Dr. Larson.
Yes, very, very welcome, or happy to be here. I'm Dr. Jennifer Larson. I am not an infectious disease specialist. I am an internist, and for a week or two more, I'm the Vice Chancellor of Research at University of Nebraska Medical Center. So I have had to continue to obtain information and then disseminate and make policy based on what we do and don't know. What I thought today is I'd kind of share some of the things that a lot of people ask me or that were uncertain the last time that I gave a presentation that might be of some interest. We are going to record this so that it'll be available for others. If you have questions, I think we'll do it at the end. If not, we will just have the recording, and certainly happy to answer questions at a later time. So, I think one of the things at the beginning that was scariest is we didn't know very much about the virus itself. This SARS-CoV-2 virus is part of the coronavirus family. There was a lot of question about where did it come from? Was it released on purpose from a Chinese viral institute? But in fact, we have good data now that it was jumped essentially from animals to humans in a live animal market in Wuhan, China. And we know that viruses can do that, and this is maybe the first of several, but there are other kinds of examples we've had in the past. I'm sure there will be more in the future. And like every virus, it can change over time. We see this in influenza. Every year there's new variants, and what we've seen again and again, even with this SARS-CoV-2 virus, is that it is changed over time. Now, with that change, the question ends up being, how is it different? And could it be scarier or less scary? And it turns out that either way, if you are at risk, it's still kind of a scary virus. The main thing that has changed with the variants as they come forward is that the incubation time, the time between your exposure until you get sick, is shorter and shorter. And as a result of that, that means that you can disseminate the virus to more people more quickly. Again, whether it is less or more scary in terms of its ability to cause disease, if you are at risk, you are still at risk for hospitalization and serious illness. One of the other things that kind of was confusing at the beginning is such a variation of symptoms that occurs when someone gets infected. And part of that may be the fact that coronaviruses have been known for a long time. There are other coronaviruses out there, cause the common cold, for example, a lot of childhood illnesses. And they like to co-infect with other illnesses, other viruses. So if they co-infect with influenza, it's going to be a little bit more like a respiratory kind of symptoms. If they co-infect with a GI-type enterovirus, it may be more like of a GI presentation. So there's some variation in terms of how it presents based on how it is presenting perhaps with other viruses, but also an individual susceptibility may make a difference. And of course, last but not least, how much of a dose one might have gotten. And of course, now we are still concerned about whether the variants make a difference as well. It is spread by both large and small droplets. The large droplets, we know, are about 5 to 6 feet kind of exposure, which is why early on we talked about this 5 to 6 feet being helpful in terms of exposure, that you would have less of that droplet transmission. However, the small droplet part was the part that we didn't know about up front, which is why the ventilation system is so important, because the small droplets can hang out in the air for a long time. So we have many examples of people from a restaurant or in a bus that were 10, 15 feet and, lots of time away from an event where someone was no longer wearing their mask and was infected and then got infected as well. So it's not just the 5 to 6 feet anymore, which is why masking continues to be a discussion. I think another thing that is perhaps confusing is that I know a lot of my patients who believe that, well, I got COVID, so I don't have to worry. I am now immune. And in fact, unfortunately, that is not true. We have many, many examples of people with each new variant that they can get COVID again. It doesn't necessarily predict how severe you might get as well. And I've certainly seen, unfortunately, cases where the first time was nothing and then the second time was very severe. So that is not like a lifetime protection. The response, why would it vary so much from that perspective? Is it the variant? I think dose does make a difference. It may be other factors that have occurred in the meantime. We know that the people who are most at risk are the people who are most at risk for many other kinds of viral illnesses too. Individuals with underlying lung disease, individuals with immune suppression on steroids, cancer therapy, things like that. The older a person is, you're at higher risk, again, because as we get older, we tend to have less immune responses to many kinds of things. And obesity seems to be a strong predictor of those at risk. Exactly what that means or why is still a little bit up in the air. It's something of an interest of mine, but I don't have answers for that at this time. Pregnant women who get COVID in their first or second trimester, their infants can test positive for COVID at birth. So it is so important that pregnant women get vaccinated as well. And that has been shown again and again, as well as the fact that it is safe during pregnancy. We know that children seem to be less symptomatic or less at risk for serious illness, but it doesn't mean that they're not at risk, which is why new vaccines were developed that are safe for children and recommended for children as well. So what about the vaccine and the boosters? First of all, they work. Over 90% of people who have vaccine and boosters are not going to go in the hospital, not go in the ICU, and not die. And that's really important. And they're safe. There's some local discomfort. Certainly some people can have short-term symptoms, but very rare other events or risks. Novavax, which is the newest vaccine out there, was developed from proteins, a very traditional kind of vaccine. It was not tested in any embryonic stem cell lines of any sort. And so for people who had a sensitivity to the concept that the other vaccines were tested at one time in an embryonic stem cell, that should not be a reason to not get vaccinated. It's also over 90% effective. Boosters are needed because the immune system forgets. After about 4 or 6 months, you have lower levels of antibodies or able to recognize the virus as it comes forward. And so the concept is that a vaccine or a booster at that time makes a difference. Obviously, one of the concerns we've had is that as the variants have changed, so has potentially the value or the duration of the booster that we are giving, which is why a new, what is called bivalent vaccine that has more kind of anti-Omicron variants in particular has been developed and is just being released right now for our oldest citizens and will be administered to healthcare workers soon. Boosters may not, however, still, thank you, perfectly match the new variants. And there may be a need to change these boosters over time, although there's no specific commitment to that beyond this booster at this time. Because, as we talked about, coronavirus works alongside and likes to infect with other kinds of viruses, it's important for both children and adults to continue to get other vaccinations, particularly influenza vaccination, which is available now, as well as for children, many of the other childhood vaccines, which unfortunately a lot of children kind of got lost in that cycle. I think I'll go then to testing. There's been a lot of, testing available. We know that because rapid tests are so available, we don't actually know how many COVID positive people we have in our community. So even when we look at the numbers and decide, the health safety consequences based on the numbers, we don't actually know what the numbers are because a lot of people don't report it. That's not only about just COVID positive tests, but also getting COVID itself, that isn't being reported into the public health facility. So just keep that in mind, that those numbers are relative, they're probably proportional, and it may depend on the area that you live in. I would say in Nebraska, we knew in the rural areas, because testing was much less available, that the availability of knowing how many people had COVID in those communities, certainly my patients who lived in those communities said, well, of course I had COVID. I had all the symptoms, sounded like I had the symptoms, never had a test, never reported. So I think that is a background that we have to take in mind. But the rapid tests are not as sensitive as the PCR COVID test. It turns out that the rapid test is pretty likely to be positive if you have symptoms. But if you are early in the disease, have a certain amount of viral particles but not reached a certain threshold, it may not actually trip as being positive. So keep that in mind. And there are other false negatives, as we say, if people do not sample well too. So there are a lot of reasons why someone could have COVID and their rapid test is negative. So if you have symptoms and your rapid test is negative, I would say go and get the definitive test, just so that you know. Because now there are, in fact, treatments available. The oral antiviral medications are very effective at reducing symptoms right away. And for some people who have risk, again, it may reduce substantially not only your symptoms, but your need for going into the hospital, which is a benefit. About other measures of protection, of course, we get to masking, and that has been a big discussion in our church and in our communities and in many other areas, from seats of power on down. But we do know that masking works, and it turns out that any mask is better than having no mask, although a bandana and a gaiter is about the same, and a face shield without a mask is kind of about the same as not wearing a mask. So if we're going to mask, having or different qualities of mask, we know that the cloth mask, if it's 2-ply, does provide protection. A surgical mask, if it is a true surgical mask, is better than the cloth mask, in part because it also has a charge in it that actually entraps viral particles. There's even evidence that if you wear a surgical mask with a cloth mask, that's better than either one alone. The N95s, or the KN95s, which are many of you are wearing them, and I realize that I do not have a KN95 in my, but it looks a lot like this, but it tends to have the ear loops just on one side or another, like the surgical masks. And it should say something like NIOSH certified, that that is about the same as a KN95 that is paper like this, where you have the two types of elastic around the back of your, there you go, there's the KN95 as opposed to, the N95 tends to have two, and they go around behind your head, which is thought to be perhaps a little bit, provide a little bit more tight kind of thing. What was that? But it pulls your hair out. That's exactly right. Yes. So KN95s are much easier to wear, absolutely. In healthcare, we actually have to not only have an N95, but it tends to be a little bit thicker and more sturdy, and it has to be fit tested. Like they actually have you wear it, and they put different kinds of things to see if you can smell it or if air is leaking. And so that's even more effective, certainly if you're going to actually work in a setting where you're going to be with COVID patients. But what we know from masking is that it helps both you, and it helps if you happen to have COVID and you didn't know it, it helps the people around you. The question is, how much does it help? And am I protected completely if I'm surrounded with people who are not masked who might have COVID? And I would say if you wear a good fitting mask, the N95, KN95, I would feel comfortable being around people who have COVID, whether they're on a mask, wearing a mask or not. And so I think that's kind of where we're at, is deciding what is my risk tolerance for myself and in this setting, whatever it might be. If you know the people that you're with and you know kind of how they've been, where they've been recently, and they don't have symptoms and they've been careful, then, not masking is an appropriate thing for you. But I think even now, when we're at the lowest level or near the lowest level in a public health safety, around 13 per 100,000 people are testing positive, whatever that means, in Douglas County. That means if you have 100,000 people in a room, like you're in a baseball stadium, 13 people at least could have COVID. And if it's in an enclosed space, then you obviously could be exposed because of those small droplets that can hang in the air. And so this masking does provide some protection for you and for others, and it becomes a risk equation for what you feel comfortable with and what you think the setting, what the risk of that is as well. Simple hand washing is great. It immediately kills viruses, so you can do that as well. Social distancing and good ventilation is certainly important. Being outside, being like the best, because you have lots of ventilation there. We've done a lot of testing within our church. The sanctuary has the best ventilation, actually, of other parts of our church. HEPA filters have been added in our church and in many other buildings, and those can be helpful too. I want to just mention briefly long COVID, because I think that's the part that, even though most people who get COVID, we have ways to treat it, and if you've been vaccinated, you're good. I think the long COVID part is still kind of a black box. Again, we know that some of the same people who are at risk for COVID are at greater risk for long COVID too. If you have prior lung disease, older, obesity, as well as any other underlying risk for immunosuppression or immunosuppressed status. There are many different kinds of consequences of long COVID, and they probably differ based on what the risk or why one has them, what the etiology is. For example, change in lung function. Certainly, if you had a very significant lung consequence of COVID, there is greater risk of having persistent lung changes. We don't know how long, and if there are other ways that we can mitigate that, but that is certainly one of the consequences. The brain fog, the absence of taste or smell, those are kind of neural types of consequences, and we don't know completely whether those are reversible completely or how long or ways to make it so. There are individuals who have fevers and arthritis. We now know that some people have reactivation of Epstein-Barr virus, and or they have developed antibodies kind of like lupus antibodies, so that even if they never had anything like this before, that somehow this virus sets them up to be at risk for these side effects after COVID, which seems much different than COVID itself. And it doesn't necessarily mean it's because they had a serious episode of COVID to begin with. A substantial portion who have COVID will have symptoms, after infection. There was a study done by the people in state of Washington, which had the very first cases of COVID, and about 13, and this is self-report, 13% at 1 month or longer after infection had some symptoms of long COVID. 2.5% at 3 months or longer after infection, but among those who required an initial hospitalization, 30% had symptoms at 6 months after infection. The risk of children and adolescents having long COVID is much reduced. So with that, again, treatments are being looked at even for against some of these long COVID kinds of things, and certainly a lot of research is being done to try to understand those things better. But I think that's part of the reason that I continue to mask, is that I don't know if I'm at higher risk for long COVID, and until we know for sure how we can prevent that, I'm not so excited about getting long COVID or COVID for that matter. So with that, one of the questions that came up actually before I came up here was the risk of paper, like order of service, and whether we could come back to having an order of service. I think that might be a more complicated question than risk of COVID, but we now think that passing around pieces of paper is not a big risk, especially if you wash your hands before you eat after handling someone else's paper, if you will. But I will leave that to Reverend Sherry to kind of respond at a later time when or if we can have order of service, but that wasn't related to where we are now in terms of COVID risk. A lot of discussion has been around singing and what's the risk to the people singing as well as the people in the pews, whether it's here in this church or some other church. And there's no question that there's greater risk if you're in an enclosed space than you are in an open space of singing if you're not masked, which is why we continue to ask people, both singers and whether you're in the congregation or up in the choir, that with singing you're projecting farther, and in the case of having a choir and the congregation we're singing at each other, that it's safer to mask. So that is an ongoing question of how to do that, even though there may be conversations in a public health kind of way, the relative risk as the total cases go down is less. It doesn't mean there's no risk, and I think that's what we all have to appreciate as well. So those are some of the questions that I got before I came up. Are there any questions right now from the audience? Yeah.
And the third COVID booster at the same time, or is it better to have time between the two?
So I'm going to repeat the question, is that the flu season is upon us. We mentioned the importance of getting vaccination for the flu as well. Can you take the flu vaccine with any COVID booster? And the answer is, I did it last time, and yes, you can. So there's no concern about getting two different vaccines at the same time, unless you have a lot of symptoms with both and you're trying to, kind of spread them out just for your own convenience. But otherwise, no, there's no concern. It's not less effective. It's not more effective. It's important to get both of those. I should also say that because of this new COVID booster, a lot of people have been holding off on the last booster, thinking that this new bivalent booster is coming, so I'm going to wait. There's also a question of, when can you get a new booster like this bivalent booster after the last booster, or if you've had COVID. There's a little bit of difference of opinion out there. It is certainly recommended that you wait at least 2 months from a COVID episode or from your last booster. But there are some who believe waiting a little bit longer would probably be good because you probably have more effect from that last booster than just 2 months worth, so more like 4 to 6 months. But there's, like I said, in science and public health, we're still kind of figuring out the best things, and at least 2 months, but by 4 to 6 months, and I would choose to go and get the bivalent booster at this time because I think it provides more protection theoretically than the old boosters did, with the exception of under 12, which is not approved. Yes?
Is there any advantage to waiting to get the bivalent booster at this time, or should we get it as soon as we can?
Yeah, the question is, and this is the games we play, isn't it? Is there any advantage of waiting on getting the booster, bivalent booster, or should we get it as soon as we can? You know, even in the flu season, I'll just tell my patients, healthcare workers sometimes say, oh, I shouldn't get it right away because, you know, it's likely to be more peak in February, so I want to have it closer to that, you know. As it stands right now, whether it's influenza or the COVID infection rate, it is so hard to predict. I don't think you can be sure exactly when the peak might be. It could be this fall, it could be next February. I think probably the better kind of measure is how long has it been since your last COVID booster. So if it's been 6 months or more, absolutely, I would get it. If it has been less than that, you know, maybe you can decide. I decided because I was going to go traveling in terms of the last COVID booster I had. You know, if you're going to put yourself in a time of risk, that's a great time to say, get the COVID booster now, because you want to have that protection before you put yourself at risk.
Plenty of it out there. So I got mine last week at Walgreens.
Okay, the new bivalent.
Yeah, absolutely.
Okay,
yeah.
okay.
And it had been available the week before, actually, and there were tons of open appointments. So it's readily available.
Yeah, Beth Conover mentioned the new bivalent vaccine is available lots of places in our community today. So if you want to do it, and the CDC has essentially said everyone should get a booster, and so it's not based on your risk profile per se, but they are actively going to nursing homes and some people or some areas where there's more risk.
I got my booster last week. When should I plan to get another booster? The next one?
So last week, I would wait at least 2 months and maybe as much as 4 unless you're going to go traveling or going to be in an event where you think you're at higher risk.
With the bivalent, yeah, with the bivalent.
I'm sorry. You got your bivalent a week ago. When would be the next one? We're still kind of waiting, honestly. So the recommendations right now have been about every 4 to 6 months, depending on your risk profile, but they're collecting information. So I think we'll have more recommendations after we get this vaccine out, or this booster out into the public.
You mentioned, I think, that the incubation period is much shorter. So how many, are there a certain amount of days that you think it's usually?
Yeah, the question is, the incubation period is shorter, so how many days? And, each variant is slightly different. As short as 2 to 3 is what they're estimating. So as opposed to 5 to 10, it's fast. But it's hard to even determine because people who have been vaccinated or boosted, they still don't get quite as much of as many viral particles. So we don't really know fully how quickly it's going around in the community. They don't even know that they may have it and are already spreading. So the data is in evolution all the time. Any other questions or comments? Anything anyone else in the committee like to add to this?
Patricia.
Yes, go ahead.
Can I have a well-fitting mask if I have facial hair?
Can I have a well-fitting mask if I have facial hair? There's no question that it is harder to have, certainly this kind for healthcare workers, it does not work if you have facial hair. So there is a benefit of not having facial hair for a K95 or a KN95 to actually seal so that you have less chance of viral particles coming in. Is it an absolute? No, it's not. And it kind of depends on what kind of facial hair, right? It's more the beard than it is, say, the mustache per se. And I think that's true. It's an important piece of any kind of choosing a mask. Believe me, there are a lot of different kinds of masks out there. There are a lot of different heads and faces, everywhere. I have someone who works with me who has a very small, narrow face, and it's like, it's a lot of the masks are just bagging around her face. And so, you have to find the right mask for you. We certainly know a lot of people who have big heads, and guess what? They need a mask that is going to be able to fit tight on their head. So everyone needs to kind of look around to see what works for you, because if it falls off or breaks or you can't wear it, then it's not going to be effective either.
I just want to say thank you. This is so helpful. I appreciate it.
Nice job.
Okay, thank you.